introduce our speaker, and her topic is pelvic floor physiotherapy in prostate cancer. Yes, it can help. That's positive, and it's going to be, I think, a really helpful, interesting presentation. Our presenter is Jodi Ganton, and she graduated from the University of Alberta with a Bachelor of Science in Physical Therapy. She has worked in multiple settings across Alberta, British Columbia, and England, initially with an orthopedic emphasis, and then combining this with a focus in pelvic rehabilitation for pain and dysfunction since 2000. Since graduation, Jodi's completed postgraduate courses in incontinence, pain, sexual health, pelvic dysfunction, and orthopedics. Jodi has expertise in the management and treatment of both male and female bladder and bowel incontinence, male and female pelvic pain, pregnancy-related pelvic girdle pain, pelvic organ prolapse, and postnatal return to fitness. It's quite a mouthful. She also teaches community education classes on pelvic health for the general public, as well as those experiencing the after effects of treatments of pelvic cancers. I didn't know there were a bunch of pelvic cancers. So. Jodi feels that education and a better understanding of the latest evidence is important for people to learn about their condition, optimize function, and return to activities that are important to them. Jodi regularly attends continuing education opportunities locally and internationally to stay up to date on the latest evidence regarding the best treatment strategies for pelvic disorders, chronic pain, and she enjoys mentoring other physiotherapists in her specialty area. Please welcome Jodi.
Thank you, Bill. So my name's Jodi. I'm a physio. I graduated in 1980 from physio school. So that was a while ago, and I took my first course, as Bill said, I took my first course in the year 2000, and a lot of people ask me, why did you start doing this type of physio? This is a real specialty. And really, it was because I got to take a free course in Vancouver, leave my small children for 3 nights. That's why, because it was free. And my kids were 4, my oldest was 4, and I have twins, and my twins were not quite 2. So it was good for me to get away from them for a little bit. And so that was the beginning, and the initial course I took was on female urinary incontinence, and then since then, as I wrote in a really long introduction, I've taken courses in for male, sexual dysfunction, chronic pain. So that's all I do now. So I basically say that if you're having issues between the belly button and sort of mid-thigh, this is my part of the body. If you have a foot problem, I'm probably not the best person. If you have a wrist problems, I'm probably not the best person for you to see. But I really love what I do, and I appreciate when people come to see me, I appreciate their willingness to share all of the difficulties that they're having, and I really like working together with that person to figure out what's the best way forward. So this particular talk is targeted towards the difficulties that people can have with prostate cancer and the treatment of. So these are the things I'm going to talk about. So anatomy, what happens with the surgery, how that affects continence. What happens with radiation, how that can affect continence. How to figure out how to turn on your pelvic floor muscles, because that's not always easy. Some urge suppression strategies, because urgency can be a problem as well, post-prostatectomy as well as with radiation. And then I'm going to talk a bit about bowels. Right? So everybody always thinks about bladder control after prostatectomy, but sometimes there's some bowel issues as well, so I want to touch on that also. Bill asked me to say this, and I forgot. So if you have any questions while I'm speaking, feel free to ask. I will also be here afterwards during the nutrition break for questions as well. So either way, during or after is good. Okay? So talking about anatomy, I'm going to move a little bit to point things out. So this is a male pelvis cut in half from front to back, right? So the pubic bone, so this person is facing this way. So the pubic bone is the front of the bony pelvis, and the tailbone is the back of the orient things. So here's the bowel and the rectum and the anus. The bladder, the long urethra to the end of the penis. The prostate, right? So looking at this and thinking about where are those muscles that we all want to try and figure out how to use. So the pelvic floor muscles attached to the pubic bone at the front. They go around the urethra. They go around the penis. They go around the anus, and then they attach to the tailbone in the back. So this is looking at them in cross-section. So, and it's all the colors on here look pretty much the same, right? So it's hard to tell what's what. This is muscle, this is muscle, this is muscle, okay? So in cross-section, they don't look like a lot. They look kind of skimpy. But if we look at things from a different view, so from the bottom end, the male pelvis, so you can see the tailbone, the anus, the base of the penis, the testes, and the scrotum. So these guys are the glutes, right? So those aren't part of the pelvic floor, but all of the rest of this is part of the pelvic floor. So when we look at it from the bottom end, it's a lot more substantial. Fair? People who study anatomy like to dissect things down to like the tiniest details. So there's basically 2 layers of the pelvic floor. There's about 8 or 9 different muscles within those 2 layers. They all have individual names, but they generally function as a unit, and we refer to them as a group as the pelvic floor, right? That's a common term that people are aware of. So floor, as a description, as a descriptor, is a good word to describe where those guys are, at the bottom, like a floor. It's not really a great word to describe how they function. Floors are pretty solid and static, right? We want closure and support from those muscles, but they also need to be able to relax at the right time, to let the bowel empty, and to let the bladder empty in men, and to have sex and to have babies in women. So it's not a static structure, right? Those muscles, they need to have some give. So I like to refer to them more as like a pelvic trampoline, right? It has to have a bit of give, right? So we don't want an old, stretched out, saggy trampoline, because that's not going to give us a lot of support or closure. But on the other end of the spectrum, we don't want muscles that are really short and tight, right? So like any other muscle group in our body, we want muscles that are neutral at rest, tighten up at the right times, and relax at the right times. Does that make sense? So there's a coordination piece of good muscle function as well as strength and endurance. Fair? So I'm going to show you my pelvis. Okay? So this is a male, is this a good spot?
Yep.
Okay. So this is a male pelvis. I just wanted to sort of let you guys see a 3D version, okay? So the white hard plastic bits are the bones. So these are the iliac crests, right? Those bones there. The pubic bone at the front, hip socket, and other hip socket, okay? And this, so this would be this way. If I go back one slide, so this guy would be here, right? So at the back, this is the lowest lumbar vertebrae, L5. Below that is the sacrum, and then the tailbone, and we have a lot of ligaments that hold us together. So our pelvis is super duper stable, really stable. So this model, obviously it has the testicles, the scrotum, and the penis. This, do you guys know what in anatomy, when you see diagrams or images, what things in yellow are? Any guesses?
Cartilage?
Nerves. Sometimes fat is yellow, yes, for sure. But this is the sciatic nerve. This is the right sciatic nerve, which goes down the back of the leg. Okay? So there's a sciatic nerve on the left as well. Looking at this from the bottom end again, so tailbone, anus, base of the penis. Okay? This muscle that goes around the base of the penis is one that helps with erections. Okay? So good pelvic floor muscle strength and endurance can also help with sexual function in the male. This model also shows, I'm going to pass it around and don't be worried about this, so you guys can look at it closer, but there's a little nerve here, so there's a much smaller yellow stringy structure. So this is the right pudendal nerve and its branches, and there's one on the left as well. So the pudendal nerves are the nerves that come off the very, very bottom of the spinal cord. So they come off sacral nerve roots 2, 3, and 4, and they keep the pee off the floor. So if you ever want to remember the nerve roots of the pudendal nerve, it's S, 2, 3, 4. So those are the nerves that go to our perineum. So there's males have them, females have them. They go to all the muscles and all the skin. So they're really important for good function. Okay? Questions about anatomy and where everything is? Yeah.
Question is, so if a person had osteoporosis and in the spine, as they age, getting more compressed, is that going to affect those nerves?
Probably not, because the pudendal nerves come off of the sacral nerve roots. So the sacrum potentially could be impacted by osteoporosis, but those compression fractures that happen are usually higher than the level that those guys come off. Fair enough? Yes. So you guys can have just don't drop it. Don't drop it. Okay. Right. So that's sort of basic normal anatomy. That's where everything is. So what do those guys do? What do they do for us? So they do a lot of things for us. So they help to clamp the tubes, turn off the hose, right? They help to control bladder and bowel. So they close off the urethra and the anus so we don't leak when we don't want to empty. They have a supportive function. More important in women than in men, but in both genders, they close off the bottom of the pelvis, basically so things don't fall out, right? They have a role to play in urge suppression. So both for the bladder and the bowel, we should have control. We should be able to calmly make our way to the bathroom, and the muscles have a role to play in that. I already touched on male sexual function, so that one muscle that goes around the base of the penis helps with erections. In women, they have a role to play as well for sensation and orgasm. The pelvic floor muscles also, if we're doing a nice relaxed diaphragmatic breath or a belly breath, they help with that as well. So they help with the diaphragm and with breathing. So they have a lot of stuff to do. Okay?
Question.
Yes.
Okay, so the urethra has two clamps, one at the top and one at the bottom. You're talking about the one at the bottom.
Oh, I'm getting there. Can you hang on for a few minutes? Okay. So what happens when you have your prostate removed? Okay. So there can be some damage to the sphincters. I'll talk about their precise location in a minute, but they can be damaged. The urethra, so if you have the prostate removed, they have to pull the end of the urethra back up to the bladder and stitch it back together, right? So the urethra is shorter, so that can make closing that off a little bit more difficult. The bladder, sometimes after the surgery, is in a little bit of a different position, so that again can make closure more challenging. There can be nerve damage. There can be damage to the pudendal nerve that I was showing you on the model. There can be scarring in the urethra, right? When they go to sew the two ends of the urethra back together, or the urethra to the bladder, there can be scarring, and that can make the urethra kind of stiffer and then harder to close as well. So those things can lead to stress urinary incontinence or urinary stress incontinence. I'll go into a little bit more about exactly what that is in a little bit. And also urgency, right? So urgency and stress incontinence can happen after the prostate's removed. So coming back to anatomy, so both men and women have an internal urethral sphincter, which is involuntary, and an external urethral sphincter, which is voluntary. So voluntary means we can do it. Involuntary means it happens automatically. Okay? So our heart beating is involuntary, but me tightening up my biceps muscle is voluntary. Does that make sense? So the internal urethral sphincter, which is involuntary, is right at the junction between the outlet of the bladder and the prostate. So when the prostate's removed with the prostatectomy, that sphincter is either gone or damaged. Okay? The external urethral sphincter, which is voluntary, is on the other side of the prostate. So it's right here, and it's kind of continuous a little bit with the pelvic floor muscles that I showed you earlier, okay? So if this sphincter is damaged or removed with the prostate, depending on how big everything is, then you don't have that involuntary action anymore. So bladder control can be a lot harder, and then you're more reliant on the voluntary or the external urethral sphincter and the rest of the pelvic floor muscles. And sometimes there's a big learning curve as to how to get those guys to fire. Does that answer your question?
Yes, to some extent. We'll keep going. I'll have more detailed questions later.
Okay.
So, if the surgeon, in doing his thing, has to dig around a bit, because the growth is beyond the normal prostate envelope, whatever your term is, does that more likely damage the inner sphincter or not?
I would say yes. Yes, it's more likely to cause issues for the nerves and because the larger the prostate is, or if the cancer is sort of taking up more
But
space.
it's extended beyond the
Yeah.
whatever.
So they're trying to get it all, right?
Yep.
So they're trying to get all the margins and everything. So I would think that's a risk factor for more muscle damage and for poor outcomes as far as bladder control goes. Okay. So urinary stress incontinence and the issues that one often has after a prostatectomy, it's kind of a plumbing problem, right? Like the tap can't close or can't close strong enough, right? So there can be leakage. I was the first time I met Dr. McCracken was several years ago, and he did a little talk to Oh, those guys haven't seen it.
Bring it here.
Move it back.
Anyway, so Dr. McCracken did a little talk about robotic prostatectomies to a pelvic floor physio group that I had started when he first came to town, I think. And he was the first, and maybe I just missed it in all my training before, but he really said, I'm just a plumber. I'm just a plumber, right? I deal with the plumbing issues. So urinary stress incontinence is very much a plumbing problem. Okay, so then, so talking a little bit more about that. So a little bit fuzzy images, but so this is a normal bladder, right? It's got the wall of the bladder is a muscle. With stress incontinence, who would like to, not the nurses in the room, does anybody, can anybody tell me what it means when I say there's stress incontinence? Like what causes stress incontinence and why does it happen?
When you laugh or cough,
Right, so what happens when you laugh or cough?
you pee.
Hopefully not, but why do you pee when you laugh or cough?
Increased pressure.
Yes.
Ah.
You're a nurse, you're not allowed to answer that.
Who said that?
Another nurse.
Okay, right, so laughing, coughing, lifting, bending over, all of those increase intra-abdominal pressure, right? And so what happens is that there's pressure on the outside of the bladder, and if the closing mechanisms aren't up to the task, then there could be leakage, right? I had this one young mom a few years ago said, this is really embarrassing to say, but I leak when I yell at my kids. So that, like that forceful yell is pressure as well. So the closing mechanisms aren't up to the task, okay? So there's leakage with stress of coughing, laughing, sneezing, jumping, running, lifting, getting out of bed, right? Getting out of bed in the middle of the night to go pee or first thing in the morning. Or even if you're been sitting for a while, right? And you're comfortable and you're watching TV and then you go to get up and you go, whoop, and you hurry up to the bathroom, right? So just changing position increases intra-abdominal pressure. So that's what stress incontinence is. So radiation, right? So whether it's brachytherapy or external beam radiation, there's an effect on the tissues, right? So they cause, both of them, sensitization of the bladder. So the bladder is more sensitive. They can cause burning. When you empty your bladder, they can cause some burning with emptying, which then the sensitization of the bladder leads to urinary urgency. So having to pee more frequently than one should or with more intensity, the sensation can be really, really strong. And leakage, urge incontinence. The bowel also can be in the way of all of that radiation, right? So some people certainly have a lot of bowel sensitization with radiation. And then that can lead to bowel urgency, and then for some people, fecal incontinence as well, okay? So going back to anatomy again, right? So whether there's brachytherapy or there's external beam radiation, you can see how close everything is. So all of the structures in the area can become sensitized. So with urgency, this image is to show what happens with urgency and urge incontinence. So the bladder wall is muscle, involuntary, but it's muscle. And it sends us messages at different, it should really only send us a message that it's near full. Our bladder shouldn't be at the front of our brain. It shouldn't be talking to us all the time. It should just be saying, oh, you know, Jodi, if you could pee sometime in the next 20 minutes, that'd be good. And then it should be quiet, right? That's how it should work. But if a bladder that's sensitized, then those messages can be really, really strong. And those messages are a contraction of the bladder wall. So the pressure that's generated is in the bladder, not outside the bladder, but in the bladder, right? And again, it's a pressure problem too, but so if this force is greater than the closing force, then there could be urge incontinence. Does that make sense? So it's a different mechanism, results in the same leakage, but it's a different mechanism. Fair enough? Questions? Okay. I'm watching the clock. Okay, so some strategies for urgency. Hydration is really important. This might sound counterintuitive, but because a lot of people, when they have issues with bladder control, whether it's stress incontinence or urge incontinence, they consciously or subconsciously cut back on the fluid that they take in, thinking that, well, if I don't have as much in there, I won't have to pee as often. But unfortunately, that's a little bit like shooting yourself in the foot, because if you're dehydrated, then your urine is more concentrated, and that's irritating to the lining of the bladder. And you probably, if anybody's gone through radiation, with the external beam, the nurses and the radiation oncologists like drink a lot, right? Have your bladder be really full during the radiation, but then also you want your urine to be very dilute, because that's a little easier on the lining of the bladder. Fair enough? Yeah.
Is that the chemical signal it sends, or?
A chemical signal that
Or the chemistry of the acidity or the pH of the urine? Is that what triggers it?
Not as far as I know. But it's that, so urine is fluid and the substances that our body doesn't want, right? So there's toxins potentially in urine. So it's the waste product, right? Urine is waste product. So if it's more concentrated, then that can be irritating to the lining of the bladder. I'm not sure that it has to do with the pH. That's beyond my
Alright,
knowledge.
but going along with that, okay, so it's 11 o'clock, it's time to have a drink. If I have a coffee or a water, which is going to be less stressful?
Well, coffee is a stimulant. So it's going to stimulate the nervous system and it can contribute to urgency. So I would say water would be less stressful. Okay. So other things to think about. So dietary irritants. So there's the next slide or the slide after talks about dietary irritants to minimize. I believe caffeine is one of those. Urge suppression strategies. I'll talk about those. There's some particular things. I'll talk about those at the end. Exercise, right? Remember I said earlier one of the functions of the pelvic floor is to calm the bladder and the bowel. So good pelvic floor muscle strength and endurance help the bladder to calm down and keep it calm until you can get somewhere where you can empty. There are some medications that your physicians can prescribe if these other more conservative things aren't working for you. With external beam radiation, usually the urgency, the sensitization settles down after about 6 weeks, after the last treatment. Sometimes it doesn't. Sometimes that sensitization lasts a lot longer. So dietary irritants, so at the top of the list is caffeine because it's a stimulant, right? It's a central nervous, we use it to wake up. It makes our bladder more chatty. So if you're having issues with urgency, I strongly suggest that you try to eliminate or minimize your caffeine intake. There's also been a bit of research looking at caffeine and stress incontinence in men. So there's a correlation between increased caffeine and increased bladder leakage episodes with stress incontinence, not just with urgency. So something to think about. Alcohol can be irritating and contribute to urgency. Spicy food, some people's systems are really sensitive to spicy food. Foods that are acidic, so citrus fruits and juices, tomatoes and tomato-based foods, vinegar, salad dressings, stuff like that. Carbonated beverages, fizzy drinks, pop, soda stream. Don't ask me about the chemistry of that. There's something about the chemistry of carbonation that is an irritant. Not everybody, but some people. Yeah.
Is that in some sort of a rank order? That is caffeine's the worst and nicotine is the best? And I'm not promoting nicotine.
Yeah, no.
Is that in turning order to that?
Good question. So I always say caffeine's number 1, alcohol's number 2. And nicotine, like it's there at the end. Not very many people smoke anymore, but people who smoke have a higher risk of bladder cancer, right? So nicotine perhaps maybe should be at the top, but it's not a common thing that people have. So good question. Caffeine's number 1, alcohol's number 2.
And vitamin C is very important here, or no?
Again, so vitamin C, I put that there as because vitamin C as a supplement is an acid. So it's something to think about. So some people use really high dose of vitamin C, it sounds weird, as a laxative, right? Really high dose of vitamin C stimulates the gut to empty. So the bottom 2 aren't in the correct order, I would say, as far as irritation wise, but the top 2, 4, 6, 7 are. Fair enough? So and caffeine and alcohol are universal bladder irritants, so is vitamin C and nicotine. But the middle bits, some people are more sensitive than others. If you are undergoing radiation, then probably the whole meal deal are things to avoid. Does that make sense? If you're not, go ahead.
How about green tea?
Green tea does have some caffeine in it, so I do suggest trying to go decaf green. So if you're not undergoing radiation and you are past that 6-week point and there's still some issues with urgency and urgent incontinence, and if you haven't thought about this list, I would suggest experimenting, right? Do an elimination diet, take one of those things out for a couple of weeks, see if it helps. If it helps, great. If it doesn't help, put it back in, take out something else. So I usually suggest people start with caffeine. Okay? Any other questions about diet stuff? It's not that those things are bad, except the nicotine. It's just they might not be great for you at the moment. Fair? So coming back to the muscles, so this just again is a schematic diagram of the pelvic floor. This is showing more of so the superficial muscles are the bulbospongiosus, the transverse perineal, so the ones that are more at the front part of the pelvic floor, and then the posterior ones, they talk about those as being the deep layer, or they sort of group them as to the levator anus. They lift the anus. Okay? So just showing you where they are again, and those muscles, they don't usually just work in isolation. They usually work as a team. They work as part of the deep core muscles. So core exercise is the catchword of the millennia for fitness, right? And there is some research and evidence to back up the connection between the deep core muscles, particularly for pressure control, for bladder control, okay? So this person is facing this way, right? So you can see at the top is the diaphragm, the respiratory diaphragm. At the bottom is the pelvic floor. At the front is the deep lower horizontal tummy muscles called transversus abdominis, and then multifidus guys in the back, and there's fascia between all of those guys. So they're the top, bottom, front, back of the abdominal canister. They're all supposed to work together. They're supposed to know what we're going to do before we do it. So they give us closure and support, right? So they're supposed to fire a couple milliseconds before we cough or sneeze, before we get up from bed, before we get up from the chair, to give us closure and support. So when I am teaching people about engaging their pelvic floor and how to do that, I try to sort of think about all of those guys working together. And people are generally more successful if they can get those guys firing in a little bit more coordinated fashion. Not the easiest thing in the world to do, fair enough. But that, you know, you want your pressure control system to work, right? Because if you can't control the pressure, you're going to be leaking all over town. Fair enough? Okay, so there's lots of, actually, before I show you the next slide, who would like to tell me how to contract their pelvic floor? What would you think about? What cue would you use? What words would work? Male words, female words? Stopping?
I'll go for it. No one wants to say it. I've always been taught to like think about lifting up on the anus, like that.
Yeah.
That was a cue word or something.
Yeah, so tighten it up around the back passage, lifting the anus. Fair enough. So that's one that can work really well for some people. In men, the only cue that has evidence behind it, and there's not a lot of research on this stuff, but the only verbal cue that has evidence behind it for men is shortening the penis. Imagine that your penis is getting shorter. So that really activates these guys, like the muscle that's around the penis, like the external urethral sphincter. So that's the only cue that has evidence.
Is that the same that happens when you finish urinating and you give it a squeeze to get the last drop out? Is
I
that
think
the same
so.
action?
I think so. But I can't do that, right? So I think so. I think you're right, Paul. I think so. So here's some other cues. Oops, where'd it go? So here's some other cues. So stopping the flow of urine, okay? Shortening the penis, lifting the testicles. So the scenario I like to use is, for guys, imagine that you're walking into a cold body of water. And as the coldness comes closer, what happens, right? Your testicles retract a little bit because it's all about maintaining temperature, right, of the sperm for the sperm to stay alive. So that's another cue that works for some people. I didn't know guys could do that, pee up the wall. Can you do that? Like can you direct, like without touching your penis, can you direct where the pee goes when you're peeing and standing?
Once upon a time.
When I was 10.
When you were 10, okay. So I found that cue in
I went to a
this.
boys' school and we had contests.
See? So this is the most recent article that I found from the Journal of Urologic Oncology, and it's called Reconsideration of Pelvic Floor Muscle Training to Prevent Entry Incontinence After Radical Prostatectomy. It came out in December, so that was the most recent one. And lead author is a physio from Australia who's done a lot of the research about the deep core muscles and stuff like that. So it's a compilation of all of the evidence to date. And so pee up the wall was one of the ones they talked about using as a cue. So maybe not. But or even just that, like I guess if you're trying to pee up the wall, your penis is gonna shorten and elevate. But it's a cue that works for some people. Tightening around the anus or the back
That was a
passage.
long time ago.
And despite the fact that the shortening the penis cue is the one that has the evidence, it's not going to work for everybody, right? So when I see people in the clinic, like we have to figure out what's the best cue for them. There's a combo cue. I didn't coin this term, the zip, but the zip is basically tightening the back. Oh, where's my model? It's back there. So the zip is basically tightening the back passage, and then imagine that you're pulling a zipper towards the front. So you're just closing everything. So, right? So starting at the back and then zipping all the way to the front. So it's like a back passage cue and a front cue. Okay? So now you're going to try. All right? So can you guys all sit square with your feet planted and your bums back in your chair? Okay?
Pay attention.
Ladies too. So just give a little, I had a conversation with a guy today because he was moving very stiffly. He had some pain and he's moving very stiffly. And I'm like, wiggle, like just shake it out. Like, so just try to let everything be relaxed and chill. And just do a nice relaxing breath. It's hard to find a muscle if we're all tense and tight. Okay? So let's start with the cues. Okay, so first of all, tighten up like you're trying to stop the flow of urine. And relax. And tighten up again like you're trying to stop the flow of urine. And relax. Guys, shorten the penis. Ladies, pull your vagina up into your body. And let it go. And pull that up in. And let it go. Pee up the wall. So ladies still pull the vagina up and in. Nice. Imagine that you're okay. And then the back passage one. So tightening up around the back passage or the anus. It's a little bit different. Maybe. And then the combo cue, the zip. So back passage, zip towards the front. And then that's it. So I just want you to try, and who felt that the stop the flow of urine cue was the best? Okay. The shorten the penis or pull the vagina up and in. Okay. The lift the testicles. Oh, okay. The pee up the wall. Okay. Tighten the back passage. Oh, that got the most. Okay. And what about the zip? The combo cue. Fair enough. So, no cue works good for everybody, right? So, one thing to think about, using whichever cue works best for you, is that you're really trying to isolate those muscles, and you don't want the legs to fire. You don't want the glutes to fire. And I was just sort of eyeballing all of you, just to seeing if the rest of your body was moving. If you're doing a good pelvic floor muscle contraction, and I'm tightening and relaxing right now, you should be able to talk, you should be able to breathe. No one watching you should know what's happening, right? It's all on the inside. So there shouldn't be this, there shouldn't be this, there shouldn't be this. So it should be very specific and very isolated. Does that make sense? Mm-hmm. And trying to figure out how to do it in sitting is not always the easiest position, right? Because there's still some gravity, you're still having to support your body. So in the clinic, when I'm teaching people this, we always start lying down, right? So there's no gravity, everything is supported, and they can really focus on what they're doing. Fair enough? Now, so there are some things you can think about, aside from just what you're sensing and you can't see. So for guys, I mean, if you could watch for things, right? So if you stand naked in front of a mirror and you shorten your penis, you should actually see your penis shorten, right? If you're doing a good contraction. Remember I was talking about how those muscles work in conjunction with these lower tummy muscles. So a little bit of tummy muscle action is fine. That would mean that you're doing a good job. It's not a suck it all in, it's just a little bit of tummy muscle action. No glutes, like I said, no body movement, no chest or shoulder lifting, and no breath holding. Okay? So I'm going to come back. So using whichever cue works best for you, I'm going to make this a little bit more complicated, and we're going to talk about breathing as well. Okay? So remember I was saying the pelvic floor should work with the diaphragm. Okay? So bear with me. Breathe in through your nose. Breathe out through your mouth. Breathe in through your nose. Breathe out through your mouth. So keep following that pattern. On your next breath out, you're going to tighten, zip, pee up the wall, whatever. All right, so as you breathe out, you're going to tighten your pelvic floor. As you breathe in, you're going to relax. Ooh. Did that work or not work? Was that hard?
But it wasn't what I was expecting.
Oh, okay. Yeah. So because the pelvic floor is supposed to work with the diaphragm as a bit of a piston. So as we inhale, the pelvic floor relaxes. As we exhale, it contracts to help push air out. And then these guys, you guys might not be able to see my tummy, but so if I'm breathing in and I'm breathing out, I'm tightening. This engages, and I'm tightening my pelvic floor at the same time. So that's the most functional way to engage your pelvic floor. That can be really challenging because a lot of us, when we're trying really hard, we stop breathing, right? Or we do I need to suck it up, so I need to go, right? So tightening on an inhale, but that's not the best way. So let's go back to that. So breathing in through your nose, breathing out through your mouth, and tighten. Relax on the inhale. So this is my pelvic floor, right? Tighten on the exhale. One more time. And tighten on the exhale. I love how you're all doing it. It's awesome. Look at you guys. Was that a little bit easier the second time around trying that? Okay, fair enough. So if it's really difficult to figure out how to do that in sitting, it'll be much easier if you try it at home lying down on your bed, not on the floor. Fair enough? Okay. So when we're thinking about that, so I was talking about like skill acquisition. So figuring out how to connect to those guys is acquiring that skill. You need to develop the skill. You need to maybe work on strength, like being able to get a better closure. And endurance, right? And then skill transfer, right? We need skill transfer because it doesn't matter if you can do 1,000 good repetitions in sitting. If you can't do that when you're walking or hiking or jumping or running, whatever you want to do, right? Like if you can't get that skill transfer, it's not really helpful, right? So there's progressions of rehab. So I usually get people to do things like lying down first, right? So lying down is generally the easiest. There's no gravity. Sitting, standing, and within each of those positions, to increase the load to build strength and endurance, you have to do more, right? So you can do more by doing more repetitions. You can do more by holding for longer. So instead of just holding on the exhale, tightening on the exhale and then hanging on, don't let go. Don't let go. I'm going to test you now, don't let go. Don't let go. Okay, and then let go. So that was a long hold. I was able to hang on to that. But I mean, not everybody can do that. So you start where you are, and then you just work a little bit more and a little bit more. So you can increase the reps, you can increase the length of holds, increase the difficulty by position, having gravity be more a factor, standing, and then movement in standing, right? Like life doesn't happen like this. Life happens with moving and lunging and bending to pick up a grandchild or the laundry or whatever. So when I give people a program, we start where they are. And then every time I'm like, okay, how you doing? What's your strength like? Okay, well I ask them, is that easy? And they go, yeah. And I go, what does that mean? If that's easy, you got to do more, right? Because you still want to build strength. And then adding impact activities, right? So if that's something that you want to do, right? If it's something that you want to do, if you want to run, if you want to play soccer, whatever, you need to have the capacity in your muscles to be strong enough to resist that pressure, that strong pressure that happens with jumping and running. Fair enough? Okay. Yeah.
You haven't mentioned the word Kegel. How does that fit in with what you've been talking about?
Okay. So I really like that word. It's kind of a commonly known term referring to pelvic floor muscle exercise. It's the name of a guy. It's Dr. Arnold Kegel wrote a paper in 1948. He's a gynecologist, an obstetrician gynecologist. He wrote this paper in 1948, and it was a study looking at women who he gave this exercise program to after they had their babies, right? And so it was a great study because what it showed was that women that worked on these muscles after they had their babies had less incontinence and less prolapse down the road. So a good study. But his name is forever attached to those exercises. So I just like to say pelvic floor exercises, right?
So, but quick question on that. Was that number 1 or number 2? Was he working on number 1 or number 2 or both?
Well, I'm not sure what you mean by number 1.
Urine or bowel?
Incontinence.
Oh, sorry, bladder. Pretty sure it was bladder. Yeah, so urinary incontinence. Yeah. Okay, so progressive loading. So I always, these words will come out of my mouth at least once with every person that I'm showing exercises to. Quality over quantity. More is not necessarily better, right? So I just had you guys do a few reps, but you can imagine that if your pelvic floor muscles start to fatigue and you're still trying to get to your 10 or your 20 or whatever, other muscles like glutes usually will start to try and help. But really that's pointless, right? Because your pelvic floor isn't going to be doing anything. So I always get people to really pay attention. So I say, okay, tighten up. Breathe out and tighten. Have you got it? Yeah, I got it. Okay, and relax. Was there something to let go of? If there was something to let go of, cool. You held on to it. If there wasn't anything to let go of, maybe it faded out before you were ready to let go. So that would be like the length of, like you maybe hold for less time than that, right? So hold for as long as you can hold well, hold for as long as you're not doing other things, and only do as many reps as you can do well. So some people come back and they're like, I get them, you know, maybe to start with 2 sets of 5, 3 times a day. Not a lot of exercise, but that's what I'm thinking they're capable of. And they come back and go, I've done 60 every day. And I'm like, well, how good were they? And maybe sometimes they were really good, but when I question them, sometimes I'm like, okay, so every one, like, could you feel it? Could you feel it tighten? Could you feel it let go? And they're like, oh, no. Okay, so back off and just do good ones. Like, why waste your time doing exercise that isn't helpful? Okay? So this is kind of skill transfer a little bit. So I like to say, remember I was saying how the muscles are supposed to work with the breath and the breath out, and this is to help to retrain that pressure control system. So if you were to, well, you're all going to try this now. Okay. So you're all going to stand up, but don't stand up just yet. What I want you to do is to breathe out, tighten and stand. Tricky. Okay, ready? Okay, and then relax. Okay, so the idea is that number 1, you don't hold your breath when you move, because if your breath holds, then that's just more pressure. And number 2 is if you can get the whole combo of doing 3 things at one time, then it will help, right? Like it will, when you get out of bed, you'll have less leakage, or when you get out from a chair. So now we're going to do the opposite. So you're going to breathe out, tighten, and sit. It's so hard. And sit back down in your chair. You can sit down. That's not going to happen, right? It's not going to be easy to do. And there is, so with women, there was a study that was, a couple studies have been done that women without any issues, given verbal or written consent to do a pelvic floor muscle contraction, 70% couldn't do a good contraction with just verbal or written instruction, right? So it's not always an innate thing to do. And we can't see those guys. Like, I can't go, okay, tighten up, I got it, right? Like, it's not always easy peasy. Fair. Okay. So this is about using those muscles functionally. And if you can't get the exhale and engage with effort, at least breathe out when you move. Yeah.
That exercise you just did there is very similar to the weightlifting exercise. It's called, 2 of them, one is deadlift and the other is split leg deadlift.
Yep.
I think I wrote your letter on that.
Yeah.
And can you comment on that? I mean, it's like, this seems very complicated to me, but what if you just sort of did deadlift and did the deadlift in the gym and did the stiff leg deadlift in the gym, is it similar?
Yeah, well, right, but I would say, are you breathing? Where are you breathing in that effort? Like, which part of that effort are you breathing? Which part are you exhaling? Which part are you inhaling? I hope you're not holding your breath when you do that.
No.
So yeah, it is. It's like just getting your pressure control system to be firing when you need it.
No, I've looked into this on the internet at Dr. Google. And the cancer people and in other schools, they sort of differentiate. One deadlift is a bad thing to do, and the other is it just a matter of getting strong?
Yeah. Have you progressively loaded so that you can lift those? Did the light just turn?
Yeah, I did. I was deaf as hell now.
So as long, like I don't really care what exercise you do or what biceps curl you do or what deadlift or squat or whatever you do, as long as you're working at the capacity that you have, quality over quantity, right? So if you're deadlifting a certain weight and you can do it well and you can breathe and you can engage your muscles appropriately during that for as many reps as what you're trying to do, from my perspective, I don't care which one you're doing.
Because you talked about the coordination of the whole core and pelvic floor.
Oh.
So in order to lift a reasonable amount, you have to, it's automatic that coordinates. So that's deadlifting seems easier than what you just suggested.
Fair, but then I would ask you the next time you go to the gym and do a deadlift, see if you can engage your pelvic floor and breathe out and put
But I
out
have to
that.
think about the breathing. The breathing is
Yeah,
pretty.
yeah, totally fair. But it's a basic principle that you want to try and apply to whatever it is, whether you're doing yoga or
Yes.
walking or whatever. Oh dear, we lost it. Did I do that?
No,
I think it passed.
this screen was working, but these ones timed out.
Okay. So if you're having difficulties, oh, go ahead.
Yeah, well, I had surgery 5 years ago and then I had radiation 4 years ago. During radiation, the oncologist said to me, we find that whatever level of incontinence you're at, when you have the radiation, you tend to stay there afterwards.
I would ask, before you had the radiation, had you done any work on your pelvic floor? Right? Because we can always get stronger, right? We can always build coordination, we can always build endurance. So that would be my sort of counterpoint to that, is what had you seen anybody like me? Had you tried to work on those exercises? Had you thought about diet? I would sort of maybe counter with that. Yeah.
But would some of that be due to tissue damage from the radiation to the area, which would make it maybe more challenging for?
Yeah, but the point was, I forgot to repeat the question. The question, or the point that you had was the bladder control that you had before radiation, or the lack thereof, would be similar to after radiation, and then
So what I'm saying, can you progress and improve on your bladder control if there was tissue damage from the radiation to the muscle and bladder area?
right. I would say maybe. Yeah, I'm a rehab professional. I'm all about, well, let's see what happens. Let's try this.
It's all worth trying. Right?
Yeah, exactly. But I'm also, give it a go, but if it doesn't seem to be working, then don't flog a dead horse, right? Like, you do the best you can and see what happens. Oh, we're back on spot. Yay! I always run into me. I'm not the most coordinated person on the planet. Okay, so, you can skip that. So urge suppression strategy, so it's just after 8 o'clock, am I okay? Time? Okay, so urge suppression strategy, so this can be helpful with radiation, or if someone is undergoing radiation or is finished, or even people with stress incontinence. Because you don't want to be at the whim of your bladder, right? Like I said before, you don't want your bladder to be shouting at you all the time. So these are some strategies that can help the bladder to calm down. So if you really feel like you need to pee, or maybe you're on the way to the bathroom and the urge is like, oh, and you're not sure you're going to make it, sit down for a sec. Sit down for a sec. Use your muscles. Zip and hold, right, to get that reflex going, to calming the bladder down. That relaxation breathing, I call it Hawaii breathing because I grew up in Edmonton, and Hawaii was my idyll. They were pretty good here. Like if I grew up here, I'd probably pick something more different. But so just trying to, because there is I haven't talked about it yet, but there is a central nervous system component to urgency, right? So if we're really stressed and if we're worried that we're not going to make it, then the bladder is going to be more chatty, and then it's going to be harder to hang on. So trying to relax a little bit, so easy to say, so hard to do when you have urgency. But with practice, that can be helpful. Distraction. So here I am talking about bladders and urine and leakage, and that might be contributing to urgency for some of you. But if you're thinking, I'm going to try and hang on to this, like if you can get your brain thinking about something else, that can be really helpful. This might seem really weird, but it's another distraction technique. So it's a sensory distraction technique. So it's giving some different sensation. So tapping and brushing the saddle area, so the part of you that would hit a horse. It gives your brain a different sensation to think about versus that sense of urge. So it does work. You might not want to do it in front of people that you don't know, but I've done a lot of talks I've done this is my 5th talk in the last 6 weeks. So I'm averaging once a week doing this in front of people that I know. But it's something that you could try, okay? Other things, a lady said this to me without me even bringing it up first. She has some urgency, and it really gets her when she's standing in line at the grocery store, particularly Costco, right? You got your cart, and it's full, and you're in the checkout lineup, and the bathroom is way over there, and you can't take your cart, and you don't want to leave your stuff. So for some people, that can be a trigger for urge. So going up and down on your toes. Okay, so if you can't sit down, maybe going up and down on your toes can be helpful. It activates your calves and your inner thighs, which seem to help out your pelvic floor. So something to try. Trying to let give the bladder a minute or 30 seconds to maybe chill out and take the edge off, and then try and go slowly. So it's about trying not to pee too often, but it's also trying not to give in to the toddler having the temper tantrum in the middle of the grocery store, which is what our bladders like to do to us. They try to take advantage. Does that make sense? Sometimes what happens, I was talking to a lady today, and she's like, I'm pretty good, but as soon as I start to take my pants down, right? So if you get into, and so this was my suggestion to this lady, and it happens to guys too, is that when she gets in the bathroom, like close the door, don't take her pants down right away. Take a minute, try to take the edge off, and then more calm, because she gets into this scenario, right? So I suggested to her that, and she's got good muscle, I know she has got good muscle, so take a minute, tighten up those muscles, relax a little bit, and then more calmly take her pants down and sit down on the toilet. Just again to change we get into these habits, right? And these habits can feed into urgency, so trying to break the habit. Does that make sense? Easy to talk about, not easy to do, right? But easier to calm the bladder down if we have good muscles, if we're well hydrated, if we don't have any or many of those bladder irritants in our diet, right? If our bowels are happy. I haven't touched on bowels yet, but I always say happy bowel, happy bladder, right? And if we're not too stressed about it. So trying to manage all of those things as best as you can, and on the whole, the sensitivity, the urgency of the bladder tends to calm down. Okay? And I always say, don't be too hard on yourself. If you're having a horrible day and you haven't slept and you feel really sick, then just go.
Any comment on the opposite problem? You're about to go into a race, you want to empty your bladder, there's a long lineup, you get to the urinal, and you can't go.
Right. So we call hesitancy, right, if you can't empty. So that is probably more that you've been hanging on, your muscles have been firing because you're having to wait, and then when it's time to actually go, they're having difficulty to relax, right? Because they need to let go to let the bladder empty. So I would suggest in that scenario, maybe do a couple Hawaii breaths, and maybe just do a couple contract, relax of the pelvic floor itself. So there's this physiology principle of reciprocal relaxation. So when you tighten up a muscle, it relaxes better after. So the same thing can work with the pelvic floor. Does that make sense?
Mm-hmm.
My answer to that would be that don't go to the urinal, go to a sit down, or if it, and then you sit down at the front, and then if it doesn't work there, push your bum to the back, and that changes the muscle.
Yeah, changes the angle. Yeah, so for some people, for guys, you guys learned how to pee standing up. And for some people, it's easy to relax in that position, to empty the bladder. But if somebody's having hesitancy, I always get them to experiment. Well, what's it like when you're sitting? What's it like when you're standing, right? And just try to figure out the best position. But in some scenarios, there's only standing, right? Okay, so a little bit about bowels. Like my stool scale. This is called the Bristol stool scale. It's a standardized scale from Bristol, England. It's from the 60s.
Poor Dr. Bristol.
Right. So there's lots of different types of stool consistency. What do you think is ideal of this scale?
Number 4.
Yeah, generally, right? So ideally we want nice, large, soft, bulky stool that's easy to pass, but easy to hold on to if you can't go, right? So, and I always go, happy bowel, happy bladder, right? So if the bowel is upset one way or the other, so hard stool, constipation, loose stool, diarrhea, either one of those extremes can be irritating to the bladder and can make bladder control more challenging. So I have my little soapbox about bowels that I get on every day, at least once, because nobody's bladder control is going to be great if they have diarrhea all the time or if they have constipation all the time. Like nobody. So I always work really hard to try and help that person figure out what they need to do to optimize their bowel, right? And some people have IBS and they're never going to be perfect, but at least if they can minimize the swinging back and forth, then there's less strain on the muscles and the bladder is generally happier and urge control is better.
Then we get into color. That's another story.
Oh, I don't care. Yeah. Yeah, as long as it's not bright red. Well, old blood or new blood, like new blood. So
White.
So normal bowel movement, like normal frequency of bowels, is quite variable. It ranges between 3 times a day and once every 3 days. If it's once every 5 days, I'm like, that's a bit slow. But it's about this, and it's about this, right? So can you hang on to it? Can you let it go? Right? So is that once every 3 days and you're not straining? Okay, that's fine. But if you're going 3 times a day and you're straining every time, my face goes like, oh, that's not good, right? Because if you're straining to empty, that puts a lot of force through your perineum. For ladies, it's a risk factor for prolapses. For gentlemen, it's a risk factor for rectal prolapses. And it can be damaging to the muscles and the nerves in the pelvic floor. So we really don't want to strain. Fair? So, good hydration. So both for, remember I was talking about dilute urine, right? We don't want our urine to be too concentrated. So for most people, we need to take in about 2 liters of fluid and eat a lot of fruits and veg, as long as we don't have diarrhea and we're not perspiring a lot, to produce about 2 liters of urine in 24 hours. So that's ideal for flushing everything out. That helps with stool consistency, of course. And then for stool consistency, we need to get a fair bit of fiber, so up to 35 grams a day. So if somebody's having issues with bowels, whether loose or hard, sometimes I suggest them that they do a fiber diary and just see what amount of fiber they're getting. Most of us don't get that much fiber. Dietary irritants, so the same list for the bladder, those things also can affect the bowel, and help with their muscle strength and endurance, also help with bowel control. And then we also need to be able to relax, right, to let things empty. Okay, I just wanted to touch a little bit on clamps. Do you guys know about penile clamps? Anybody tried one? Which one?
One that's shaped like a cockpit condom.
The sling.
It's pacey. No, it's a I forgot the name of it now.
Okay. Did you like it?
Oh yeah, it's better than the torture one on the right.
The torture. So you thought the pacey cup was the torture one?
Mm-hmm.
It's a different, comes in different sizes.
Yeah.
Oh, okay.
Mm-hmm.
Right. Fair enough. So the Cunningham is the one that's most common. It's not round. I don't know if anybody's tried the Cunningham one. I don't think it would be as comfortable as one that's round, but I don't know. It comes in couple different sizes. The pacey cuff is a newer one. I've had one gentleman try the Cunningham and another gentleman try the pacey. They both were okay. So it depends. With a clamp, you don't want to wear them forever, like 2 hours is usually the max. You wear them overnight. You want to have good skin integrity. You want to have good sensation. You want to be able to take them off, right? You have good dexterity, you be able to take them off. They can help people return to activity that they might not do if they were worried about pads and being wet all the time, right? So I had one gentleman a few years ago who could do his daily 1 hour walk and stay dry, but when he did his weekend 3 hour walk, he needed a little bit extra help. His muscles fatigued by the end of that. So we got a clamp just for that one day, right? So we just use it for that. Another gentleman I saw play tennis, and he didn't want to go back to tennis and worry about being wet and wearing pads and everything. And I the first time I saw him, I brought up the clamps, and he was like, I don't want to go there. But the next time, then a couple days later, he phoned the clinic and asked for the name of the clamp and where to get it. And then he tried it, and he was really happy with it. It's not necessarily the long-term solution, right? So this gentleman with the tennis, he was just at the beginning of his road of getting his muscles firing. But it can help people return to their activities, right? Which is really important for a quality of life. So they can be helpful in some scenarios. Usually there's a qualifying statement some of the urologists don't want people to use clamps until they're, a year post-op. Sometimes they want you to, really make sure that you worked on your muscles and you're not just relying on the clamp, that you want to get that voluntary control. Fair enough? There we go. I'm at the end. So thank you for coming and listening to me. Any other questions?
Come on, Jodi.
Yeah.
How soon after prostate surgery or radiation would you recommend starting pelvic floor physio?
Fair enough. So sometimes people are referred pre-op or pre-treatment, which there is some evidence to show that figuring all of this stuff out before you go into the surgery can be helpful and help you become drier sooner after the surgery. Post-op, you have a catheter in for 10 days, 12 days, whatever, post-prostatectomy. So can be quite a steep learning curve of how to figure out those muscles after you get the catheter out, post-prostatectomy. And for some guys, it just takes them a day or two and they figure it out, and that's awesome and that's great. I'm happy to see anybody anytime, but usually there's such a steep learning curve right away after having the catheter out that you want to give yourself a chance to do that. But if there's still significant issues after 4 to 6 weeks, then I would suggest checking in with somebody like me. And if I see somebody pre-op, then I say, okay, when's your date of surgery? You're gonna have a catheter in for this long. Okay, so 4 to 6 weeks after that, let's book another appointment, right? Just to check in. And I've had, in the last year, I've had at least 2 guys. They come see me pre-op, they figure it out. We're booked, they're booked for post-op, but they call me after, 4 weeks after their surgery, and they're like, I'm good. I'm like, okay, that's fine, right? So we cover all of the exercises and everything, so
There's no, like, is there any, is it ever too soon to come see after surgery?
after surgery, well, if you have the catheter in,
Yeah, then it's,
that would be just.
but basically as soon as it comes out? then-
Well, I would give a week anyways, probably. Yeah. I would give a week. Yeah. And radiation, I don't know that I would place any restrictions on anything with radiation. Some people, it's personal choice, right? Some people just want to be done with it and then do their rehab. There are some things that we could maybe talk about in the midst of all of that to help with the symptoms of radiation. And then, yeah, sometimes, 6 weeks after the external beam is finished, then everything settles back down again, right? So I think it's kind of personal.
Okay, well, thank you very much. I think it's great to have clues, what to watch out for, and we've practiced, so this is fabulous. So thank you very much.
You're very